Humans' health and well-being is key to a prosperous future. But the landscape is changing. Individuals are taking health back into their own hands, urging for transparency, more options, and less red tape. NEOM is creating a new, holistic health and well-being ecosystem that caters to all world citizens, where people, not hospitals, are at the center of the system and can live, thrive, and be heard. Supported by the latest medical advances with a focus on proactive prevention, not just treatment. The knowledge is there and the precedent has been set. Sweden is a leader in the telehealth space and uses a collaborative, patient-centric approach. South Korea offers high-quality universal healthcare backed by extensive research. And Singapore and Japan are home to those who live longest in the world. But it's all happening in isolation. Imagine what we can do together. NEOM will tackle some of the world's toughest health problems, pioneering a new standard of well-being, with a focus on pain management, muscular and skeletal diseases, and cancer, and a balanced approach to overall well-being, mind, body, and soul. Co-created with and personalized for the NEOM community, encompassing integrative care and complementary medicine, and at the forefront of research, telehealth, and digital solutions. NEOM is committed to livability, longevity, and quality of life. The future of health and well-being starts at NEOM.
And now looking forward to our next panel, which is going to be chaired by a gentleman who has been a very good friend for a long time, Mr. Hal Delano Roosevelt, known as Del, and he is President and Chief Executive Officer of the US-Saudi Arabian Business Council.
Ransel, thank you for inviting all of us and giving us the opportunity to be involved today in this very important conversation. Ladies and gentlemen, my name is Delano Roosevelt. I am the President and CEO of the US-Saudi Business Council. The reason that Ransel and I thought it might be interesting to run that clip on NEOM is one of our Chairman's Circle members, and the head of NEOM, Mr. Nadmi Nazar, is one of my board of directors. NEOM is a giga project in Saudi Arabia that, what you just saw, health is a major component of this 10,000 square mile project, of which is aimed to be a zero carbon operation, and there's tremendous opportunity. But as we relate to health today, I would like to first of all recognize my colleagues that came on just prior talking about the Internet of Things. Well, that's a tough act to follow. That was a fascinating hour, and where it's very much high-level thinking. What we're going to be talking about this hour is the patient improvement through community participation in healthcare services, where, after all, I think that we would all agree it does boil down to everything that we do in healthcare really should positively affect the community and the people of which we all strive to serve and provide the best healthcare that we can for. So today, I'm not going to go into the backgrounds and read bios of the three panelists that I have joining me today, because it'll take away from the time for you to hear about their subjects and to possibly have a little conversation, a little leftover time to discuss afterwards. Today, in this order, you will be hearing from Dr. George Cheriyan, who is CEO and Chief Medical Officer of the American Mission Hospital in the Kingdom of Bahrain. George will be able to tell you a little bit about himself before his comments. Following George, we have Ms. Emmeline Roodenburg, Head of Healthcare Life and Sciences for KPMG Middle East. And then to wrap things up, we'll have Robert Kramarz, Founder and Executive Director of Intelliversity, USA. So without further ado, I think let's jump right into it. And I would like to ask Dr. George to say hello and give a brief introduction, and then on with your thoughts, George, please.
Thank you, Del. Thank you, everybody. Thank you, Ransel, once again for inviting us to be on this esteemed panel. My previous life, over the last 30 years, I lived my life in the four walls of an intensive care unit, a neonatal intensive care unit. So where there was a lot of technology, there was a lot of data. But over the last several years, my life is turned around. And now I am much more conscious of what we call population health and community health, because I run the oldest mission hospital in Bahrain, which is 120 years old. It's called the American Mission Hospital. So I wear a completely different hat, and my thoughts are also different when I look at what I see from my vantage point in providing how does the community come into the sphere of health, the healthcare space in all. I will take you on a very brief journey of how we came to be where we are today. Hospital-based care has dominated just about everything, including budgets, and became the primary source of delivery of healthcare over the last 150 years. The early 20th century saw the movement of healthcare shifting out of the home and the traditional healing methods in the community to large centralized bodies called hospitals. Along with worship places, it became the centerpiece around which townships and cities were built. And over time, it soon became apparent that these focused factories of healthcare became quite good at dealing with the very sick and dying, and improved survival, decreased maternal mortality rates, improved infant mortality, and so on and so forth, which was absolutely fantastic. And we all are beneficiaries of the great improvements that hospital-based care brought to our communities over the last 100 years. But if you think further, it had little or no impact on the wellness and prevention of illness in the community as a whole. So individually we benefited, but if you take the community of population health as a whole, the benefits were kind of in the middle. Quality of care through the measurement of outcomes was slow to catch on, and now we have a metric for pretty much everything that we do in the hospital with the adoption of technology and automation of pretty much anything we can do in the hospital. However, when you translate what we just heard about AI and automation on the hospital side, it is very difficult to translate that kind of research into the community, where the models of provision of care is completely different. Now, we have now become so used to a fee-for-service model in reimbursing healthcare. Hospitals and physicians were the big beneficiaries of this model, along with big pharma and the other technology giants, adding both to the survival and cost of hospital care. However, with this, the cost of healthcare has steadily escalated in all level income countries, high income, middle income, and low income countries. But if you look at the United States now, it's nearly 18-19% of its GDP that goes towards healthcare. And however, if you look at the total quality or the lifestyle indices, that significantly hasn't moved in the right direction. In fact, for the first time, survival rates are beginning to drop in the US. And the children of the new generation are not as living as long as the adult parents. So it is, I would be, I'm not underestimating the fact that newer models of healthcare is in the bus, both in the media, in all the circles where healthcare is talked about. And it's a source of intense debate in achieving the twin goals of improving health, but containing costs. And this terminology, value-based healthcare and population health, are not new whether in ideology or methodology in how to spread scarce resources across countries. The 18th and 19th century saw pandemics, several global pandemics that claimed millions of lives. And there existed lessons that mankind learned from these pandemics. And however, when COVID landed on our doorstep in January of 2020, we seem to have forgotten some of these basic steps that we need to take to sort of manage a pandemic. Public health and containment of infectious diseases became a priority, which was population-based from the 18th century onwards. And now we are in the accelerated phase. We are nearly there in developing a new COVID-19 vaccine, whereas when it came to smallpox and measles, it took several decades before a vaccine became available. Community-based preventative care never received the attention or the funding that hospital-based sickness care received over the last 100 years. So community-based care has always been the poor cousin of the hospital-based industry. The pendulum, though, has sharply swung or is beginning to swing the other way, with a focus on prevention of illness and targeted interventions of lifestyle and nutritional changes to modify the impact of the modern plate of NCDs. This paradigm shift to wellness from sickness care will be the new norm for global health, be it any country. Value-based reimbursement models to encourage prevention and appropriate early intervention for high-risk groups seem to have theoretical advantages through measurements of its effectiveness in community-based settings. But the science is still not robust as we have it in the hospital-based care system. At the American Mission Hospital in Bahrain, which is a small country, population of 1.5 million, half of which are expatriates from various nationalities, and half of them are Bahraini. So the population is pretty small. So interventions can be tracked slightly easier than in a big country. What we have started doing as part of our thrust for wellness care and preventative healthcare, we have developed a model called ASK. And the ASK model, A stands for awareness of what you're trying to look for, and the S is the screening part, and the K is the knowledge which we have to impart to the patient whom we are trying to get. So the A part and the S part and the K part are demographically divided. If you're talking to teenagers between the ages of 15 and 20 in universities and high schools, the ASK is different for them than if you were targeting women in the reproductive age group, where they ASK and different. That is different from males who are between the ages of 45 and 60. So these awareness programs that we have developed is to target select populations to make them aware of the risks that today's world in terms of lifestyle, nutrition, exercise, and other things that we do to our bodies, and environmental factors. That's another whole different thing that has added a layer to all of the NCDs, how we can actually manage this in the community. By the time they come to the hospital with type 2 diabetes and renal failure, the game is lost. In fact, Bahrain, as with the other GCC countries, as many of you know, has got the world's highest incidence of type 2 diabetes. 30% of our children are obese. 40% of the women in 40s and over are obese. So these are major factors that actually impact on the health of an individual. Though the problem starts in the community, we can intervene in the hospital. If you think about it, the hospital visits are very brief, but the population exists in the community. So we have now flipped the paradigm so that we start looking at our patients through the community. And we are hoping to use technology to sort of track and trace, not the COVID, I'm not talking about track and trace COVID, but track and trace all the high-risk things of NCDs and age-related factors out of the community and bring them into an increased awareness so that prevention, targeted prevention, can make a difference in the outcomes. I know this is unlike hospital-based care where you can look at 100 open heart surgeries and the outcome, you can check it out of a computer. Population health takes a lot more time. It's patient, it's evidence-based. It is not as sexy as the hospital-based databases. However, the real impact on healthcare, global healthcare, lies out in the community. And I will stop with that, Deb.
George, that was fascinating, and I thank you for your comments. I do have one quick question that I'd like to pose before we continue on. You and I have had this conversation many times with respect to preventative versus reactive medicine and treatment. And what you're talking about certainly makes the case for preventative. Are you finding that the insurance programs in Bahrain, unlike those in the United States that seem to be only reactionary, very few programs really support true preventative medicine, which in my humble opinion will save millions in the long run? But are you finding that shift is taking place where they're becoming more supportive of preventive programs and medicines, treatment?
I'm pleased to say that at least 25% of all insurance companies in Bahrain now actually provide preventative programs and wellness screening. So that is a good start as far as we are concerned.
Absolutely.
They understand the significance of screening.
Yeah. Wonderful. Well, hopefully a number of other organizations will take the lead, because that certainly will be key. Dr. George, thank you so much. And hopefully we'll have time for more comments. Moving on, Emmeline, thank you for joining us. And please, the floor is yours.
Thank you so much. It's my absolute pleasure. I've been listening in, and not only to the previous session, but it's fascinating discussions. I'm honored to be with you today. To quickly share my background, Emmeline Roodenburg. I'm a lawyer and economist by background, but I've been focusing on large healthcare transformation for over a decade. I'm Dutch, but since I joined KPMG in 2011, I worked across the globe, of which 4 years in New York City, in Toronto, and I moved with my family to Riyadh in 2019. So therefore, I'm very happy with this forum, so I can bring my expertise today specifically from my experience in New York and from what I've experienced over the past a year, 2 years here in Riyadh. To echo Dr. George said, I think population health management and the shift towards preventative care, so much has been said and done about it. You can't argue with it. It's an absolute no-brainer. If you allow me, I'll speak a little bit more today on the involvement of the community, because from the real population health management, you see it's still predominantly provider or government-led, but the real initiatives from the community are fascinating, and I think we can learn a lot, and we can move the needle quicker if we focus better on it. In New York, I have to say, I was one of the lead directors for the DISRIP program, which was initiated in 2014 to reduce the avoidable hospital use by 25% in 5 years for the complete Medicaid population. It was an $8 billion program, and KPMG was the state's #1 partner to reach that goal. We're now in 2020, so we should have the results. We didn't reach 25% of avoidable hospital use. We did reach 21%, which is really, really impressive still. And I think a big part of it was not so much looking at the hospital, but looking at the people who should not be in the hospital, which is avoidable ED visits, avoidable readmissions, and length of stay, where the solution was indeed downstreaming of that care and downstreaming or providing that care in out-of-hospital settings. So strengthening the primary care system was definitely a main component in that, but involving the community as well. I think before diving into the community involvement as accelerator for health outcomes, it's interesting to just take a step back, and everything that we're now inventing used to be normal, right? In the olden days, we helped each other as a community, and through many factors, including industrialization, urbanization, as well as the female workforce participation, we lost our sense of community. And in the US, it's already more so than in Saudi Arabia, but unfortunately, we're catching up pretty quickly here as well. And sometimes you have to recreate what you want to be part of. I think the power of the community to increase health is greater than any government, physician, or private institute can achieve. As you know, in Saudi Arabia, we're moving from a centrally organized system to a decentrally organized system, where we've identified 21 clusters, geographical areas, that need to be the ones that provide care. They need to be transforming into accountable care organizations by 2030. And they're now really starting, and for the past couple of years, because some of them are already up and running with their population needs assessment, to then identify what kind of initiatives and how do you organize care based on your demand and your capacity. At the same time, the payer, provider, and the regulator are being split. And I think the payer also plays a really crucial role if you talk about involvement of the community, which might sound counterintuitive, but my big plea for today is that we should heavily invest in community care. Sometimes we think, oh, it's community, so it should come for free. I think that's an absolute wrong thought. We should invest, we should pay for it, because it will, at the end of the road, be much better in terms of your prevention agenda, but much better in terms of outcomes and in terms of cost. So to further elaborate on the experience I had in New York, so I had the privilege to work in this project for 4 years, where one of the main components I said was strengthening of primary care, but also co-locating primary care with behavioral health care, mental health care. The other thing is we really focused on who shouldn't be in the emergency department. And here we involve the community, where, and these are real numbers, right? We looked at the frequent flyers in the system. We all know they are 5, 3, sometimes 1% of 80% of the cost. And some of them were in the hospital 15 times a month. We could easily identify when they would be there, and when the weather was bad, when it was getting colder, they were going more often. When there were pizza nights, I do not make this up, in the ED, they would obviously be there. And there was a television, which is nice because you have something to do. When we actually took them out and said, for the 16th time this month, you're here, let's spend 10 minutes on what you really need. And one of the answers, obviously, for this one is, well, we need shelter. And then you can say, okay, here's the address of the shelter, but that doesn't work. So we actually placed employees of shelters in the ED. It's all about the warm handoffs. And that made a major difference. And these people didn't come back because there was a structural solution. What we also saw in terms of the preventative agenda and the education agenda, that food markets and schools started to involve in this program, which was really beneficial, and it really accelerated the effect. On the other hand, you can also look at the commercial side. From my experience in Canada, where they are creating Ontario health teams, you will see that Walgreens and pharmaceutical companies are actually interested in this, because they say that they see that there's a real play in investing upfront. The other thing, so 3 examples. This is the New York example where community involvement really accelerated. The second one is peer support. I think across the world, I do not have to come up with all the research that has been done on it, but peer support, if you talk about community involvement, is absolutely crucial, and it really deserves more and more investments, because, and if you look at the mental health issue, which is for Saudi Arabia specifically, still a chapter where there's a taboo, and peer support is something that you can provide more low-key. People can share their experience. And if you professionalize that, the benefit can be very high. Improvement of the quality of life, improvement of engagement and satisfaction with the services overall and the supports, improve whole health, including chronic conditions like diabetes, decreasing of hospitalization, overall reduce of health costs. And the third one, I was happy that you showed the video of NEOM. We're very proud of it here in Saudi Arabia. Healthy cities. The WHO is heavily promoting healthy cities. In Saudi Arabia, we have received last year 5 certificates for healthy cities, so we're very proud of that. And NEOM is an absolute leader in that. In KSA as well, where we have a population, we heard the numbers of Bahrain, but in Saudi Arabia, where the numbers vary from 25 to 40% of people with diabetes or in a pre-diabetes stage. It's absolutely stunning and alarming. And the Healthy Cities Initiative is a bright spot in that darkness. I think to wrap up, today I think we're not answering a question of community involvement would help or population health. But I'm really focusing on the community, which we think is a sort of deed of volunteering. It's a no-brainer if it would help. The question is how to incentivize the community to go back to what we in the olden days thought was normal, to help out each other. And the answer is not to sit back and think that we will get back to the olden days and then maybe in the nature of people, because things have changed. We need to incentivize it to make it count. So there's if I can leave anybody of you with a thought today, that's what I want to stick, is make it count by 3 things. Certification, so make it official. People who provide community care, it is good to have certain certification. It doesn't need to be complete education with a training and schooling, but certain certification makes it official. Can be on several levels. Second, make it beneficial. Make it beneficial for the people who are actually providing community care. So pay for it. It is much cheaper than hospital care. It is absolutely worth it. And 3, awards. Community care will still, as I hope from the bottom of my heart, be provided by people who do it from their own good. Also, if you're paid for it, it doesn't mean it comes from your own goodwill. But if you make it known, if you award it by just campaigns, you will make people proud, and you will make it known to the community, and they will invest more. So make it count by make it official, certification, make it beneficial, payments, and make it known, awards. And that's my plea for today. Happy to answer any questions, and I'm looking forward to the discussion.
Well, wonderful. Emmeline, my gosh, first of all, I just what hits me right off is KPMG is very fortunate to have you on their team. People think of KPMG as this global, large organization that operates as a mega consulting firm in so many areas, and we don't really hear about the concern that the company might have a heart for community. And you're certainly changing that perception among people right in the last 10 minutes of your concept of serving community. And I'd like to mention real quick to all of our attendees and all of our friends joining in this conversation, none of these 3 panelists know each other or have had any direct interaction prior to this, and yet we hear this wonderful thread being woven from a 120-year-old medical organization in Bahrain to KPMG, and now we will move on to Robert to see how he's going to tie all of this together. But this is this is very exciting that this trend towards serving the community, this concept of serving community, really has taken a foothold on the planet. And let's hear what you have to say, Robert, please.
You got to unmute first, right?
There we go.
I was just looking at these images and I realized I've been indoors way too long, and I'm lack suntan here. Compared to some of you guys, I'm pale as a ghost. But
Robert, it's all makeup.
It's all makeup.
It's all makeup. Yeah. So don't worry about it.
I'm honored to be here. I'm really honored to be here. Del is the right way to refer to you, right? Yeah. Emmeline, thank you for those remarks. Wow. Need to learn a lot from you. In fact, from everybody. George, you inspired me with Bahrain's experience. And I have to also call out Dr. Ghazan Abu Alfa, who yesterday inspired me to higher levels of thinking, and Dr. Amiri, or Al-Amiri, about the experience in Dubai also inspired me this morning. So I'm honored. I have a lot more to learn than I have to teach, but I want to tell you what we're up to. You know, my Intelliversity is an innovation accelerator. We work with venture capital firms to transfer more money to the real world type practitioners, innovators who get things done in the real world instead of just theoretically. So we call ourselves the Innovation Accelerator for the real world. The idea of Project Jericho came up about 10 years ago, and it just recently, because of this crazy year, has suddenly taken off. And because the circumstances are right, with the Abraham Accords and telemedicine and all the other things, look, the way we're able to reach out to each other right now is really unprecedented. Can I share a couple of quick pictures? Is that going to work for you? Let's see if I can do that. So this is a town of Jericho. It's kind of an oasis in the Jordan River Valley. Can you all see that? Just shake heads. Yeah. Okay. Cool. It's not all that green, but that's a nice shot of the greenest part of it. It's a historical region, oldest city on earth, they say. If you notice where it's located. So let's see if I can. There's Jericho. Can you see my pointer?
Yep.
So it's actually 50 kilometers from Jerusalem, and it's 50 kilometers from Amman. There's a direct route between the two, so it's kind of a mid place. It's also a nice, clean helicopter ride right up the Jordan Valley from down here, which is Neom, right here on the Gulf of Aqaba. These are short distances. If you've ever driven this road, it's a straight shot right up the valley to Jericho. Leave aside the security checkpoints and all that, because we'll deal with the politics later. And of course, it's Saudi Arabia and Jordan all around it, and it's a fairly close shot to Egypt over here. On the north, Lebanon and Syria right up there. If you look kind of a zoom out on the whole Middle East, it's a midpoint. And the reason we chose Jericho for this, and I'll get into what we're going to do in a moment, is that it's there's a lot of it's a very water-rich area. There's a lot of land available for real estate development, and it has a reputation as being a resort. It's not surrounded by the political instability of the West Bank itself. So it's something that's kind of a pure and sense of restart there, which we'd like to take advantage of. It is a Palestinian-controlled territory, which means that so far as the Middle East is concerned, we're talking about a familiar cultural and language setting. If you look at this one picture here, this is the Allenby Bridge, which is the crossing across to Amman from Jerusalem. It's a nice 2-hour drive from Jerusalem, but you got to cross that bridge. Oops. Well, that was the bridge in 1967. This is where it is today. So the world has made a lot of progress in connecting. It's really up to us here to complete the connection process. I'm going to return now to the regular screen. The purpose of Project Jericho is kind of fourfold. One, win-win economic growth for the whole region, transfer of knowledge and expertise, and particularly in oncology and cancer care. And that's where we'll need some feedback, a lot of feedback from everybody else here. The raising of health standards, both in the affluent areas and the less affluent areas, and the positive impact on peace negotiations on an ongoing basis. We're well aware that things like the Egypt, Jordan, Israel Accords kind of gone nowhere. There's some progress been made, but not a lot. And you have cases like the Tashkent Agreement between India and Pakistan resulted in further war, not less. So unless you have a foundation and basis in mutual collaboration, which medical diplomacy and healthcare diplomacy is the best way to do that, these peace agreements are not going to be lasting. So we would like to use this project as a way to inspire a real foundation for peace negotiations. But whether or not that occurs, the economic and health benefits are enormous. The whole idea is to create a medical tourism center in Jericho or the surrounding area to serve both Palestine, West Bank and Gaza, and the Gulf states, and with any cooperation from Jordan, Egypt, Lebanon, Syria, Iraq, and the North African area. We're very ambitious. It has to be a dual focus because you have affluent people who can afford to make that short trip and stay there, and then you have people who really can't. But of course, you have right in the surrounding area, within a half an hour, you have a major refugee population. And believe it or not, people in refugee camps get cancer too. It's, we don't think about it very much, but it's just, in fact, more prevalent amongst the less affluent, because there are many causes of cancer, and they are not, they're more prevalent in the refugee camps of all places. So the advantages of a local community, we consider this a community-based resource, even though it's something clinical-based, so it's not just in the community, but it's not hospital-based. Because naturally, for acute care or major operations and for major radiology, we're gonna have to make a trip to at least in the short term, to a hospital setting. But the benefits of locating cancer care in a resort setting relates to the need for 6 to 8 weeks of chemotherapy, typically, and then you have recovery, and then retesting and possible additional radiology and surgical intervention. So you need family support, you need peer support. And Dr. Abu Alfa pointed out to me that the genetics are very important in cancer. You have a completely different genetic situation in the Palestinian genetics, and there's actually 2 different groups. From the Gaza area and the West Bank, 2 different genetic groups, but it's very different from what you have in Singapore. So to ask people in the Gulf states to travel to Singapore for cancer care, which is where a lot of it goes now, or the US, doesn't take advantage of what we know about the local genetics right there in the Middle East. And you really have to know the local genetics. So there's a level on the cost advantages of being treated locally, and so the travel is less extensive and the stay is less expensive. So there's the benefit to the visitor is enormous, and the benefit to the local community is enormous. Add to that the benefit of knowledge transfer from the best researchers and scientists in Israel, the US, and elsewhere, now facilitated by telemedicine and by teletraining, lead to a very compelling argument. So that's what Project Jericho is all about. And I think it also, it's in the infancy stages right now. It needs a lot of advice and support, feedback, counsel. And the politics will be very difficult, but we'll deal with it. It also illustrates the value of taking into consideration the local community and how it interacts. And I want one more fact on that. What is 80% of cancer treatment all about? Prevention. 80% is prevention. And most of prevention, we can talk about community health, but most of prevention nowadays is screening, right? If you get your prostate exams, your pap, mammograms, right? You get your skin cancer screenings. Those 4 or 5 basic screenings and lung cancer screenings can eliminate 80% of the hospitalizations, right? Quick and easy stage 1 and 2 treatment instead of stage 4 treatment. Well, that can only be done on a local basis in primary care. So that has to be inspired, and we think can be inspired by a community-based solution. All right, so that's in a nutshell what I've got to present. I'm looking forward to getting your feedback. Thank you.
Robert, thank you. You're taking on a Herculean task, I think, in the politics alone, but it seems that if there was ever a time for Project Jericho to exist, we're certainly stepping into that frame. I wish you all the best. Again, we're talking about, you're talking about a concept that is trying to bring community-based healthcare to the scene, and certainly this would be that would be a terrific way of doing it. As we're moving along here, it's we've probably got about another 10 minutes, I think, at the most. I'd like to just open it up to the panel now for any comments, Dr. George or Emmeline, of what you heard from each other that you might want to comment on, or maybe ask questions that is in your mind of what Emmeline is doing or what Robert is doing. And Dr. George, do you have anything that you'd like to add or question?
Like two comments, one on Emmeline's presentation and one on Robert's. Emmeline, fascinated to hear the work that KPMG is doing across the waters in Saudi Arabia. I was in Bahrain, Saudi Aramco, for 18 years before I moved across to Bahrain. So I know the scene pretty well there. Something that Emmeline said, I'll just expand on it. See, the community has to be the target. You're targeting everything to the community. The community is also the resource. As soon as we empower the community, as Emmeline rightfully pointed out, the community is a very powerful resource to bring about solutions that, other healthcare providers might not be able to find. And the third thing is, the resources will have to be poured into the community to increase the capacity for the community to respond to its own needs. So we have to have a partnership between the community and the state or the government or the payer to see where are the gaps within the community where funding is poured in so that the capability and the capacity within the community is actually improved. That is critical for any community-based programs to work. And following on what Robert just said about the Jericho program, Robert, I can tell you, with the signing of the peace accord between Israel and Bahrain, we are at the American Mission Hospital in Bahrain, we are already communicating with Hadassah University in Jerusalem.
Hadassah, good.
Yeah, Hadassah. We are communicating with Hadassah to look at teleradiology, and some of the technology that Hadassah has, and they are very keen to come and work with us. So that's already happening. Yeah.
How about Sheba? Have you got a chance to talk to those guys?
No, we did. So, at the moment, the peace accord has just been signed just a few weeks ago, and we've already been in communication with Hadassah.
That's really wonderful to hear. Wonderful to hear.
Emmeline, any thoughts that come about or questions?
Yeah. I think to add specifically on activating the community, I think, and this is also, C19 also accelerated this. And what I see in the transformation here, so like the Vision 2030 was announced in 2016, and for the last 4 years, all of the beautiful strategies have been developed, how it actually should look like. But if you really want to move the accountable care organization in 2030, you need to start implementing. You need to start implementing fast. That's the type of work that I love to do. But what is crucial in this, and what I'm very happy that the kingdom is now actually investing it, is the voice of the patient, or the voice of the consumer, per your preference. I know that some people are pretty particular about that, but in the transformation in Saudi Arabia, you see a real upcoming in that. But what I would like to add to it is the voice of the community, because what we're saying, okay, yes, the community, they can help, and they are an absolute key in the whole healthcare transformation agenda. And the goals in many countries around the world are very, very similar. But why don't we ask them how they can help? Like we are asking the patients or the consumers what they need, why don't we ask the community, how can you help? I think we should be much, much better at that.
That's a great point. Absolutely. And that I think should be, that singular point should have more of a global ask as well. This is something that you know, here in America, Americans, they at the end of the day, they tend to get things right. And the same within Saudi Arabia, and the people, no one knows your community better than the people living in it. And they definitely need to be brought into the conversation because they can offer tremendous insight. And sometimes the simplest questions provide the simplest answers to the challenge. Robert, anything from you? Final thoughts or questions?
Well, I have many more questions than answers, but
that's the idea.
There's one thing I'd like to suggest, that we consider this mid-range between community and hospital is the local clinic level and primary care, and that's where we're focused. So that's kind of a third level in between. Mm-hmm. Like your thoughts on that, both of you. But the other question is, you know, will affluent citizens of the Gulf states, will they travel to a resort in the Jordan River Valley if it's suitably equipped and beautiful and comfortable? And will they bring their families for an 8-week vacation? Is this really a dream, or is it practical, or is it just a fantasy?
Are you asking for a feasibility study?
Definitely asking for a feasibility study.
No, I'm just joking. Will they travel? I don't know. I think, you know what, because in Saudi, we're investing so much in tourism. Yeah. The country is really opening up. I don't want to say I'm stuck in the country for the whole year, because it's actually lovely to be here. I couldn't think of a better place to be stuck. The government is really encouraging people in Saudi to actually do their vacations in Saudi Arabia as well. Yeah. There's a lot to explore here, but right. If you make it attractive, if the prices are good, but for most, if the quality is good, I wouldn't see a reason why.
Mm-hmm. It's also a combination with Neom and Jericho, not too far apart. It's about a half an hour by helicopter. So,
well, that might provide for a very interesting conversation with between your team and the Neom team as to how some sort of a sister relationship could be created between the organizations, and that's certainly doable from within this within this framework that we have set up today. You know, I have had the luxury of knowing Dr. George for at least 10 years, and working with him directly when I was living in Bahrain up until November of last year. I have had the honor and pleasure to sit on the board of directors of the American Mission Hospital. It's fascinating to see what Dr. George has done with talking about serving the community, of having a large central hospital, and that's been the norm for, as Dr. George said, 120 years. From that to opening up 4 community clinics, full service. I think, are all of them 24-hour George, or are they?
Yeah.
All the 24/7, servicing the various communities within Bahrain, and on a much smaller, more intimate basis. And it's been such a success. And it is all about listening to the community for what they need. And maybe, George, if you have just take a couple of minutes to describe the latest project that's happening for the Kingdom of Bahrain through the American Mission Hospital.
We are wholly a community-based healthcare system. We are the only not-for-profit healthcare system, I think, in the GCC. And what we're doing is we are building a state-of-the-art. It's not a big facility because we know the future of healthcare is going to be out of the community. But for particular reasons, patients will still have to come into the hospital. So we are building a completely green, lean, digitized healthcare facility, just 100 beds, because most of the care is going to be out in the community, because we've got ambulatory care centers where 95% of the care is going to be held. And this new facility is just to take care of mainly deliveries in children and admissions, post-op, acute rehabilitation, and then back in the community. And we are digitizing the whole process, and we are experimenting to see how connected can we stay with our patients out of the community, monitoring them real time. And I've had some experience looking at similar command centers that they have in Saudi Arabia, but this is a lot smaller because the population in the community is a lot smaller. So it's easy for us to execute that in Bahrain rather than a much bigger country to spread out like Saudi Arabia. So that's a new project. We're quite excited about it. Yeah.
That's terrific. I have one question that's come up here on the board, and I'm going to, I think it would be best directed to Emmeline or Dr. George. Dr. George, you've spent so much time practicing and working in Saudi before Bahrain, and Emmeline, of course, here right in the middle of it. This question, I'm going to just read it directly, and I'll leave it to either of you to jump right in. It states, I'm from Saudi Arabia, and there's one thing that I've noticed is that the medical files in government sector are separate from those in the private sector. From your experience, do you believe that there will be a joint medical data that would make healthcare much more easier and simpler moving forward? Either of you want to address this comment?
I can address that from the Bahrain point of view. The Bahrain is actually establishing not a single EMR or EHR. However, our systems will communicate freely because Bahrain is introducing a universal healthcare system where the insurance is going to be the way. So all the payment gateway for pharmacy, prescriptions are going to come through a single gateway. So we will be sharing files, electronic healthcare record between the private sector and the government sector. And the government has taken the initiative for this, not the private sector.
Wonderful. Emmeline, any thoughts from you on that? Or?
Yeah, absolutely. I mean, when I hear that, my first reaction is, with all due respect, I wish it was that simple. I wish we were that advanced that we had one EMR for the public sector and one EMR for the private sector, because we have some ways to go for the public sector. There is no universal EMR at the moment. We're working towards it, but to have one sort of truth across the full care continuum, that's definitely not what we have right now. So first and foremost, full action on that. It is in progress, and the government is very ambitious on that. And as you probably know, our Excellency the Minister and the Vice Minister, they both come from a technical background. So that's a blessing for the kingdom. And then linking to the private sector is the next step. I would also say I, as a consumer, hope to have my own electronic medical record. And I hope with the full transformation in 2030 that many people will hold their own medical records.
Wonderful. Well, Robert, Dr. George, Emmeline, I can't thank you enough. You've given us all a lot of food for thought. I know that our attendees that have joined us in this conversation would most likely have more questions, and I'd like to just say to the group as a whole, to the attendees, if anything that you've heard during this last hour from Dr. George or Emmeline at KPMG or Robert with regard to Project Jericho, or even NEOM, as you saw in the video opening up, if any of this has you interested in how to pursue any projects or opportunities, we at the US-Saudi Business Council, this is our mandate. This is what we do, is we create opportunities and explore opportunities for companies, US companies mainly, because it's the US-Saudi Business Council, to create opportunities for international cross-border transactions. We help you on the introductions to these opportunities, and if you find something that does interest you and you're ready to move forward, we at the Business Council stay by your side through the entire process of until you're actually in business, so to speak. So if there's any interest from you, we can certainly be of assistance there. I know that Ransel will be making all of this available to you after the event through his website. And I would like to thank Ransel and Sam and the whole team at C3 for making this such a seamless and facile event today, and look forward to participating more in the future. With that, Ransel, I'd like to hand it back over to you. Robert, Dr. George, Emmeline, thank you from my heart for your participation.
Thank you very much.
Well, thank you all. It was certainly a worthwhile and very impressive session to be part of, and I do appreciate your time.